The role of B-Raf targeted therapy has changed a lot over the last decade. It really came out swinging just over a decade ago with some early hits on the board in clinical trials, but now seems to have been largely overtaken by immunotherapy. Before saying anything else, I think it's really important to be mindful of the fact that targeted therapy only applies to patients with the right tumour genomics. So it's sobering to remember that this entire line of therapy isn't relevant for the majority of melanoma patients. Now, regarding B-Raf MEK inhibition, long-term follow-up of the key targeted therapy studies like BRIM3, COMBI-V, COMBI-D, and Columbus, they all show 5-year overall survivals around the 30 to 35% ballpark. And that's for patients who receive combined B-Raf and MEK targeted therapy in the first line. However, survival outcomes vary quite a lot by subgroup depending on other risk factors like LDH and the number of sites of visceral disease. So those survivals could be as low as 10 to 15% or as high as 55%. So at least for the total populations, targeted therapy survivals appear somewhat numerically lower than what was observed in the key immunotherapy trials of regimens containing anti-PD-1 agents. The key question is therefore around, the key question around targeted therapy amounts to a question of when to use it in relation to immunotherapy. And one pooled analysis of pembrolizumab studies found that although B-Raf mutant patients receiving pembrolizumab after prior targeted therapy exposure did have lower response rates and landmark survivals, in that study, the pre-treated population also had worse baseline characteristics. And there was a pooling of B-Raf wild type with targeted therapy naive B-Raf mutant patients. So these data were effectively comparing patients across different lines of therapy. Fortunately, we now have clearer data about immunotherapy to targeted therapy sequencing, which does indicate that immunotherapy first is the superior strategy. And this is most robust for ipilimumab plus nivolumab combination therapy, courtesy of the phase 3 DREAMseq study. So this study compared outcomes of patients who received either ipi-nivo or dabrafenib and trametinib targeted therapy first, followed by the alternate regimen after first progression. Now, while targeted therapy response rates were similar in either line at 43 to 48%, ipi-nivo responses were blunted by about a third when given in the second line, from 46% down to 29%. And this was reflected in a significantly longer overall survival in patients who started on the immunotherapy regimen. The phase 2 SECOMBAT study was non-comparative in nature, but showed similar numerical trends for patients receiving similar regimens of ipi-nivo, and in that case, encorafenib plus binimetinib targeted therapy combination. Now, of course, the superiority of first-line immunotherapy does not mean that that's the right choice for everyone. We tend to consider targeted therapy, obviously, as a salvage option when patients progress on immunotherapy, but the potentially high rate and rapid response that can be achieved with targeted therapy has particular application in patients with high volume disease, rapid progression, or marked metabolic derangement at presentation. Targeted therapy has efficacy intracranially, so there's also a role for patients with resistant or rapidly progressive brain metastases who are not suitable for stereotactic radiation or surgery, as the use of whole brain radiotherapy in general is really decreasing. Targeted therapy may also have a more prominent role in patients who require heavy immunosuppression at baseline, as we would expect that immunotherapy could have a lower degree of efficacy in that group. Similarly, targeted therapy might be the preferred initial choice in patients with severe or uncontrolled pre-existing autoimmune conditions who are considered to be too high a risk for immunotherapy toxicity with an immunotherapy regimen.